Implant impression techniques. Dental impression is a negative imprint or a positive digital image display of intraoral anatomy used to cast or print a 3D replica of the anatomic structure that is to be used as a permanent record or in the production of a dental restoration or prosthesis. Objectives of making impression in implant dentistry is to accurately relate an analog of the implant or implant abutment to the other structure in the dental arch. Also, to copy the same position of dental implant inside the patient mouth to the cast, where the lab will put abutments and work in it. We need many impression equipment to complete taking the impression. The first is the impression post that facilitates the transfer of the intraoral location of the implant or abutment to a similar position on the laboratory cast. They may screw into the implant or onto the abutment and are customarily subdivided into fixture type or abutment type. A one-piece cupping screws onto abutment is used if the abutment does not need to be changed on the laboratory cast. A one-piece transfer is attached directly to the fixture if the abutment does not need to be changed on the cast. It should have a flat side if angle correction will be necessary. A standard transfer impression post is a sleeve that matches the implant diameter. A screw penetrates through its center. The screw can be placed through the impression post sleeve and carried to the mouth with the standard hex driver. A two-piece pickup used to orient the anti-rotational feature or to make impressions of very divergent implants. Impression cupping. The impression cupping is self-seating. This means that the screw will not engage the implant if the cupping is not correctly seated. The radiograph is recommended to see if there is any interference or a risk of soft tissue interrupt, and we can see here there is a space between the impression cupping and the implant, and this means that there is soft tissue interrupt or it is unseated correctly, while here there is a correctly seating and no space between the impression cupping and the implant. The laboratory analogs are made to represent exactly the top of the implant fixture or the abutment in the laboratory cast. Therefore, they can be classified as fixture analogs and abutment analogs. The laboratory analog corresponding to the size of the implant. The other important equipment is the abutment. The abutment is the portion of the implant that supports or retains a prosthesis or implant superstructure. A superstructure is defined as a metal framework that attaches to the implant abutment and provides either retention for a removable prosthesis, bar for overdenture, or the framework for a fixed prosthesis. We have three main categories of implant abutments, according to the method by which the prosthesis or superstructure is retained to the abutment. The first group are abutments for screw retention, uses a screw to retain the prosthesis or superstructure. The second group of abutments for cement retention uses dental cement to retain the prosthesis or superstructure. The third group of abutments for attachment uses an attachment device to retain a removable prosthesis like O-ring attachment that used in overdenture. Here we can see many types of equipment, starting from the cover screw that is used after surgery, and the healing abutment, and different type of abutment for screw retention, cement, and for attachment, and also different type of transfer cupping used for indirect and direct method, and the different type of analog and cupping with the prosthesis screw. Also here we can see different type of equipment that can be used for different method of impression taking. For the impression can be taken on two levels, either abutment level, which involve the placement of the abutment analog, a device that mimic the abutment, and the second type is implant level, which involve placing an implant analog, a device that mimic the implant on the stone model. This technique used in single stage implant such as blade, subperiosteal, and root form implant. The abutments are attached to obtain a working or master cast to fabricate final prosthesis. This prosthesis approach may be called a direct prosthetic options. This is the abutment. Acquire this cast by making an impression of the abutment using any comfortable techniques, and then application of gingival retraction cord around the teeth or the implant, and elastomeric impression. And we can take the impression by applying the elastomeric impression material and applying a temporary crown, and this is the final. The advantages of direct prosthetic options are familiar to restoring dentist, no laboratory analog components are required, splinting crowns together is less complicated because manufacturer precisions for analog is not required and transfer of component is not required, and lastly, reduce cost because analogs and laboratory fees for abutments are eliminated. So this method is by preparing the abutment in the patient mouth and taking the impression, and then preparation of the prosthesis outside in the laboratory, and then return and applying it on the patient mouth, like the applying of conventional crown. And The disadvantage of direct prosthetic option are that the abutments are prepared in the mouth and retraction cord placement is required in aesthetic zone or when additional abutment height is required for prosthesis retention, and a different transitional restoration is often fabricated than the option during implant body healing because the abutment is inserted. Now the second method, which is the implant level impression technique. An implant level impression may be made at different stages during treatment and is dependent on operator preference, also called indirect process. At time of initial surgery for one stage technique, or to enable the delivery of a provisional crown at second stage surgery, as second stage surgery following soft tissue healing after a second stage. Two different types of impression posts are commonly available to transfer the relationship of the implants from the patient mouth to a master cast. These posts differ in design based upon impression tray technique utilized, for example, open or closed method. The impression taking, we described the common techniques, the conventional techniques, and then we have now the closed tray technique, which is the indirect, and open tray technique, which is we start with the indirect method. Impression cupping making with classic impression tray analog attached to impression post and seating back into. We have many advantage and disadvantage for this closed tray technique, or we call it the indirect technique. The advantage that patient does not need as much of a vertical opening as with an open tray technique. Handling is simple. Price impression tray does not need to be modified. We can use any tray that is suitable for the patient mouth, and this method is fast and not need many time. The disadvantage is considered to be less accurate, especially for multiple restoration. Implants are deeper. If impression posts are more than 10-degree divergent, impression material can be distorted upon removal, and the wax in the screw head must be put to have an accurate impression. First, we start to choose short or long hand driver, and then choose the appropriate hex driver and use the appropriate hex driver. Most common hex driver is 1.20 millimeter according to the system we used, and then we start by removal of the healing abutment. After the surgeon open by puncture the area and put a gingival former or healing abutment, we call it. So we start by removing it after about 10 to 14, and we check for tissue invagination. So if there is any discomfort or there is a inflamed tissue around this area, so we remove the excess tissue from the prosthetic table of the implant and take a time for healing before taking the impression. If there is no sign of inflammation or growth of abnormal tissue, so we go to the second. We put the impression post, select the proper impression post that have the same diameter or suitable diameter with the fixture from the data sheet of the. So we select the proper impression post. So we select the proper impression post and seating the impression post inside the fixture in the opening, and then take an X-ray to see if it is fully seated or properly seated, completely area. Take an X-ray. This is mandatory when seating an impression post, cannot be visually confirmed, so we take an X-ray to be in the safe side about the seating of the impression post within the implant. So we can see that the impression post must be fixed impression post. This hex area will be no interference and completely fit within the fixture, and we can see it in the X-ray that the impression post, and this is the screw that fit the impression post inside the implant. Then we can close the opening in the head of the impression post by a small piece of wax, so that no impression material will be inside this opening and which disrupts the impression. So we can close it with the wax, block out with the wax, and then take the impression by using impression material, polyvinyl, polyether impression material, polyvinyl siloxane. Any elastic impression material can be used to completely cover the impression post with the impression material before seating the Then we seated the impression tray and take the impression and inspect impression accuracy. After that, we remove the impression post from the patient mouth, from the implant in the patient mouth, and must be reseated in the impression by attaching analog to the impression post. So we must attach an analog that resemble the implant in the patient mouth to the impression post before seated it in the impression. And we can see that there is a flat surface in the head of the impression post that will aid in reseating of the impression post in the impression. Then reseat impression post into the impression by attaching the analog to the impression post, and be sure that the hex of the analog will be fitted completely with the hex of the impression post by screwdriver. Then we secure the healing abutment tightly into place by hand using the screwdriver, and sometimes we need the torque meter. Then the impression with its component will be sent to the lab to complete the prosthesis, and don't forget the shade selection and height of the patient.